Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD Podcast. Toro, we're together again.
Oh my God. And we have somebody extra special. I was just talking about her, and hopefully we get a blush out of her because she inspires me. Our guest, Brian, you inspire me, but she really inspires me.
I just little bit
I am
inspire you,
touched.
right?
Yeah, she inspires me. She's been an absolute warrior in her clinic in Israel, and she is an absolute warrior now here in the States, coming back. She's a Harvard-trained, Columbia-trained endocrinologist, and she is changing lives. She's worked with Mark Cucuzzella on an amazing grant, and they're now working in a very underserved area near our practice, working with patients on Medicaid, working with patients who are in homeless shelters, SNAP benefits, and really absolutely changing their lives with a low carb diet. And she's thinking big. I've talked to her. I've had the pleasure of talking with her at some of these press conferences, and I can see the way she's thinking. It's like we need to stop thinking just about our own tiny little practices, Dr. Brian and Dr. Tro, and we need to think big. And she's thinking big, and she's doing great things. And I'm excited, Brian. Brian, I know he's like, I know Brian's chomping at the bit here too, but I'm
I hope I
excited.
can get a question in somewhere, Toro. We'll see.
Well, no, I'm so excited. I don't know if I'm going to let you get a question in. So Dr.
know.
Glandt, Dr. Mariela Glandt is joining us today. I'm so happy. I'm so happy you're here.
I'm honored. I'm really honored. Thank you.
I thought we had a
guys.
rule about letting endocrinologists on our show, Toro. What happened?
Well, she's a good one.
I know. There's a few out there, right? That's
They're
exciting.
like
That's
two
all
of
good.
us, right? I think you met the other one. That's it. I'm just kidding.
No, there's some
But-
great endocrinologists. I'm really happy. I've been really happy, and it's so hard because I'm just curious. Like when you first started doing this kind of medicine, did you get blowback from other endocrinologists or people that you were working with, or did you kind of had free reign to do your thing?
Yeah, no, for sure. So I actually had lunch with Roshni, Dr. Roshni last week or so in New York.
Amazing.
And we were just so excited to meet because it's just like, we had so much pushback. We had more than pushback, more just like ignoring, like they don't want to hear what we have to say. So it was really exciting to meet the other adult endo. I recently have been meeting some more. So we're starting to
It's growing.
come around.
It's
Yeah.
growing slowly.
Yeah. Slowly. But yeah, we're the last bastion, as they say.
In
to
Israel,
really-
is it as hard? Like I know in India, I remember looking on Twitter thinking, I'm so glad I don't live in India because people were getting death threats. It was like really, really
Yeah, I know,
nasty.
Yeah, it wasn't so bad. It wasn't that bad in Israel, not at all. But it's just tough. We are taught something different. We're taught to the usual food pyramid, and we actually don't spend any time at all talking about lifestyle. We go straight to the meds, and that's what we know how to do. This is what we learned to do. So I can't blame them, but it's just too bad, But we got to change that. That's what we're here for. So. It's just it's tough for doctors who have trained that in a certain way all their life to suddenly be told that they're doing it wrong or could be doing it much, much better. So it's a big threat. It's a big threat. So I give Jess, as we were just talking about, Jessica Apple, I give her the credit for making me see the light. She really she pushed me. And or gently pushed me, I would say, to say, hey, there's a different way of doing this. Her and her brother, Sam Apple, both saw the light way before I did. So,
oh my God! Now I'm putting it together.
It's the same Sam Apple that we know.
It's the same. So now I'm putting it together.
Holy
They're
cow!
warriors. Okay, got it now.
Yeah.
Because Jess,
wow.
Yeah. So Jess, just to clarify, I'm interviewing Jess tomorrow morning because I'm
Oh,
so excited about her and what she's doing, this metabolic revolution that she's trying to
amazing.
start, and that I'm going to try to make in Washington, D.C. Get,
So
10,000 people to go to DC and say we demand metabolic health. So
let's do
this is
it.
now I know who this is. This is Sam Apple. Got it. I'm putting it all
Ravenous,
together now.
ravenous Sam Apple.
Yeah.
Ravenous
Wow.
apple.
Cool.
Okay.
Yeah.
So this is like a family. So you guys are like a huge like low carb like you guys are a powerhouse over there. Yeah.
Listen, you should see Jess and I, we nerd out on WhatsApp. Just like, did you see that study? We're like so excited about things for years, it's just so much fun to have somebody to discuss this with, you know. So
And you
like
grew
I
up
was just,
together.
yeah, we're
Is
best
that
friends since
amazing?
age 10. Yeah,
That's
yeah. We're like
amazing.
sisters.
That is amazing. So,
Yep.
so she was the instigator of you looking at this?
Yeah, she was. She really was. She
Wow.
had a website called sweetlife.org, a nonprofit that really brought, taught people about low carb and as I always say, like, of course, intuitively, I understood that low carb made sense. Of course, you shouldn't be eating sugar, but to really take that leap and understand what low carb really means is a whole other ballgame, right? It's a whole other, so, it's slowly, we both matured together and understood the depth of this, and not just she came at it from a type 1 perspective, which in a way is, it's like, don't eat sugar and things will look much better. But then she also understood the whole insulin resistance part, and how sometimes, or how insulin resistance also precedes many times that we know of autoimmune diseases. So that's also a whole interesting angle that we kind of discovered together. So it's been a real journey with her. Yeah. And it's really fun to talk about this in this context. So
Well, it's fun because we learned so much from you and what you're doing. And so, I think you're tackling one of the hardest communities, right? Tell people what you're doing that don't know. Just tell them a little bit of background what you're doing. Um,
sure.
with
So I guess I'll just step back a bit and tell you, we have a clinic, or I have a clinic, where we've treated some, by now, I think we're getting close to some 4,000 patients. Um, and this was a private clinic, where I really had the opportunity to develop what I thought was like the ultimate or the more optimal treatment for reversing type 2 diabetes. And I was really lucky because I didn't have a boss, or I was kind of a mushroom. This was in Israel. So I was like by myself. So it was a wonderful opportunity because I didn't have to report to anybody. Um, while actually most of my colleagues do have to. So this is an advantage I had. So once I saw it and I understood that this is amazing, we started implementing this, and this was really like a beta site for learning what the right protocol is. And we're still learning, it's a process. We're always trying to make it better. But because it was a private clinic, I also had, patients knocking down on my door saying, please give me a GLP-1. And so we also learned, how to use the best drugs and when not to use the best drugs, and how to deprescribe these drugs, et cetera. So it was a really nice playground, I would say. And really, my passion is, I used to work in the Bronx many, many years ago. And I have a soft spot for this place because people are very underserved. The amount of just, you get on the train in Manhattan, and I get on like in Midtown, or Upper East Side, and the waist size just grows and grows and grows as you go up north into the Bronx. And it's really, it's not just that, they're just not just the fact that the BMIs are so much bigger, but also just the disparity that there is. And so my co-founder Ido Ophir and myself, we had a dream to really make this available to underserved communities. And this is how we started. And we were lucky to get to do a pilot in the Bronx with Med, and they have it's a large healthcare. They provide a lot of primary care. They're very big actually in the Bronx, and I really thank them for their forward thinking and their openness to this. And we were really able to change lives. It's really amazing how much we think that underserved, or people who don't have access to or basically or live on welfare or have Medicaid are very they're not going to be able to do this. This is for the rich. This is meat and fish, and these kinds of things are not for underserved populations. And that's what we were, and they're never going to be able to do it. Also, they're never going to be able to do it. That was like the prejudice. But wow, it's exactly the opposite, I have to say. I actually have more compliance from this population than in a lot of my population in Israel. And I always joke because it's, I call it the CEO syndrome. When a CEO walks into my office, I'm like, oh no, because chances are that they're going to take about 80% of what I say, but then 20% they're going to do whatever they think, because they're used to running their life, and they're intelligent, and they read a lot, and have a lot of resources, and also a lot of temptations. And so what happened in this population is that I think they're actually so tired of being given more and more and more medications. They arrive with a list of at least 20 medications, and they actually are open to a real solution. And so I'm finding that the compliance here is actually better than in my normal clinic. So this is a really nice surprise.
That's actually amazing to me. That's really, because that's always the thought. It's like no one's listening to me. Then you realize they were listening. We're just giving the wrong advice.
Yeah, absolutely. Absolutely.
So what's the motivation like for you and for your patients? They want to be healthier?
Yes.
They
They
want to get off
want to be
meds?
healthier. Yes. You know, we can keep taking insulin, or actually, what if we actually change the way you eat? How about having a burger on a plate and getting off the insulin? How's that for an idea? And they like it, always give them a choice, and they choose. And they choose, unbelievably, they always choose the lifestyle change. So we have to give them that option.
I wanna explore this idea a lot more, because there's so many themes, and I'm just gonna list them out, and maybe we can explore them. One
Sure.
is exactly what's happening to these people's lives. The article in Medscape that Nina Teicholz wrote covering this was actually peered back the curtain into a person's life who was living in a shelter, somebody who had diabetes, and was basically, was given access to the Mediterranean diet, and it didn't work. And so this idea of, what those lives actually look and feel like, I hope you can expand on that for us, because I know, sometimes we talk about it, but people don't know what it feels like to be in a single room occupancy apartment, or to be in a shelter and
Mhm.
still need to reverse your PCOS or obesity or diabetes. But there's so many
Yeah.
other topics to like cover there. One is, we've done food pantry programs, they've never dented A1C. And here we have a low carb approach, with your clinic and your company, and it's having an impact. And then, so the disparity of that data, like the data from Faith DM trial and other trials that have, were long-term aggressive, whole grain and vegetable promoting programs that didn't help. And then the last one is this idea that we need to give processed food to the poor, and saying that we
Yes.
shouldn't give processed food is being disenfranchised and elitist. So I'd love for you to like tackle these three, because I think that they're important to this discussion. Walk us through those lives. People want to know, how does the data that you're seeing compare to the Faith DM trial, which was a bust, and is it elitist? Are we elitist here that we should, impose a low carb diet on people who absolutely don't want it?
Okay, let me see if I remember the order of this, but
Yeah.
basically let's think about, even within this population, there's a gamut, right? There are people in shelters and there are people who do have a job and are working and are trying to make ends meet. And I think what strikes me is the amount of challenges that they have. Okay, so for example, today we were talking about a patient who lives with a hoarder. So he doesn't have the capability of having any food around because it's just gone. And so he also doesn't have anywhere to cook it. So in a very small space. So we're teaching him how to use a microwave for cooking healthy food. How you can boil an egg and there are many. Well, we were also thinking in the shelter also you don't have access, you can't cook your own food, so how do we do that? All of these are challenges that we have been dealing with, and how to, when you get the food stamps, how are you going to spend that money? Well, it turns out actually that junk food is really expensive, and since you're always hungry, it ends up being much more expensive than you think. It ironically, patients are saying that they're saving money. So, one of my patients says that when she tried, to eat very healthy, she would always go and get fresh produce because this is what she thought she had to do. So she filled up her pantry with fresh produce, and half of it had to be thrown out because she didn't get to finish it. So she's now saving money by buying, frozen food and frozen vegetables, and like your frozen meat and frozen vegetables, and it's lasting her much longer. And she's she says, I'm actually saving money. Those are her words. And the challenges, I think, are, they're just so many. For example, during the pilot, two of our patients had a family member who was shot during a robbery and died. Okay, this is like unthinkable. We had, in the month of May, 10 patients had a close relative die for whatever reason. I mean, the statistics, there's so many things, so many types of tragedies happening all the time. A lot of it has to do with jail, for example, either relatives coming out of jail or coming into jail, or, this type of thing that we don't deal with in our daily life. It's an unproportionate amount of difficulties. And then having to raise kids. Some of them have like 6 kids. And, how do you cook for them? And how do you also, even coming to mind, like, how do you deal with the grandkids when the parent of these 2 parents that were shot, suddenly they're basically in some ways orphaned. I mean, they have parents, but anyway, they're complicated stories of very complicated family dynamics, very broken families. This is really what we're talking about. Actually, a few of our patients are ex-heroin addicts. None of them are actively on heroin. A few of them are alcoholic, very difficult to treat. Just difficult situations.
And exercise is not safe to go walking around your community like a lot of us can do, or go up for a walk in the morning, or by yourself. And I mean, that's unthinkable. So there's so many barriers to getting healthier that there's a lot to overcome. And I've always felt this, and Tro will probably agree with me, but the effects of being under chronic stress, having gang members in your neighborhood, worried about being extorted, being mugged when you go out, losing family members, that stress affects cortisol, insulin, all these stress hormones. So being stressed constantly doesn't help the situation either.
Absolutely. And shift work, I forgot about that also, right? So patients that work overnight, very hard, right? So it's definitely hard to to see the improvement there, it takes a much longer, you know, and so we
So
don't
how did you
we
show improvement? Was it through education, persistence, community,
so
like talking to them more? Like, how do you think you're having success in the hardest to reach community?
well, we've developed an app, and the app has several components to it. One is it's basically a vehicle to talk for the patient to talk to the doctor, and they get assigned a coach. And we're basically the coach and the doctor are basically the cheerleaders that really take them through this journey. So we teach them about the basics of the diet, of course, and then the patients are in communication with us on a daily basis. They engage a great deal. 50% of them check into the app once a day and chat, but they're also uploading their labs, whatever, you know, their whatever we want to check, maybe their weight or their glucose levels, etc. And then we follow them. And what I find is that I'm sure you guys find this too, the importance of the coach, right? The coach is like it's like your life, you know, it's really more than just you're the person telling you what to eat or not to eat, but they're also the ones that are supporting them through all these really difficult situations. And I think that there's an immense value to that, and it adds a lot to the journey and also to the compliance. So I think you know, it's a combination of various things. It's a combination of course, a diet that works, and therefore that in and of itself is a positive reinforcement right away, right? Because you know, you don't have to convince somebody to do something when they see the results from anything, right? We're talking not just reversing diabetes, but to all the other effects like improvement in PMS, improvement in the amount of bleeding in the cycles, improvement in headaches, asthma, you know, debilitating migraines, you know, the amount of things that improve, you guys are very well aware. But
Anxiety and
it's just
mood, right? Anxiety and mood. If you're a stress eater and your stress gets better because you're eating right and you're getting good nutrition, guess what? You don't stress eat as much and you deal
exactly
with the
so
stress that much better.
exactly. So we've definitely already proven the improvement in depression and anxiety already.
Wait, can you
We're
say that
tracking
again?
this fit. Improvement in depression and anxiety.
Okay, so when Tro and I said that like 7 years ago, we got mocked by doctors for like 3 days. So I just want to make sure they hear it in case they decide to listen to us at some point.
Well, we needed a
You guys
Harvard
are
trained,
ahead of
a
the
Leo
curve.
trained.
We need a smart endocrinologist. We'll say we're not, but she is. She knows. She's seen the same thing. It's amazing though. That is the amazing thing that we see. That's like, you know, I was just at a conference the whole first day and into the second morning was all mental health, schizophrenia, bipolar, anxiety, depression. So people are struggling with that, and you don't think diet has anything to do with it. That is why we have a problem in our with our healthcare system. So
Absolutely.
that's
So
my
that
commercial, Tro. Sorry.
I couldn't agree more. You know, it's just so exciting to see that because we know as clinicians for all these years, when people come in with anxiety, you don't want to put them on a benzo. Like there's not a lot of our tools are very limited. So it is so great to be able to offer this. But this was like a side effect, right? I wasn't really treating them for depression at this point. In the future, we will go straight to depression. But right now, we were just trying to deal with the obesity and diabetes. And yet, as a nice side effect, I mean, a huge amount of patients, like 50% of our patients have diabetes, depression and anxiety anyway. So we are tracking that and seeing how much of an incredible improvement. Anyway, what I was saying is that we have the diet that as the main tool, but also we adjust the medications to make sure that there's no big, you know, we can get in trouble if we do a low carb diet with the wrong medications, especially for diabetes and also for mental health, but and for many other things. But it is important to have a doctor there, making sure that this is well taken care of. And then there's the whole psychological aspect, which is the just like you guys, you know, the focus on sugar addiction and understanding that we are really addicted to foods, to all these processed foods that are killing us and controlling our lives, right? So this is a big part also of the program. So and all of that combined with technology makes it available and scalable.
No, I just have to just ask one more question, Tro. Sorry. Are your patients mostly doing finger sticks for glucose? They're not doing CGMs, I would imagine.
Correct. So the patients that are on insulin are able to get CGMs. The trial that we're doing in West Virginia with Dr. Cucuzella is with CGMs, but the majority of patients are not on CGMs. I mean, it's a wonderful tool, but not all of them have it. And
There's
we have,
practicality, yeah, is what you can
right.
get. Yeah. Our patients
Yeah.
were a little spoiled because they're of a higher socioeconomic class, so they can afford to pay cash and get theirs, right? But not everyone's in that situation. So the fact you're doing what you're doing without that technology shows that what you're doing is working.
Yeah. In the end, you know, it's a great tool, but we can do it without it too. So it is a great tool though. But it's
I'd love to ask like a little bit more. Look, you know, I'm a believer in monitoring, coaching, right? Monitoring, coaching, food addiction, low carb, great doctors, right? Caring team, easy access, right? This is the future, right?
Right.
And if you're not doing that, I feel like you're not doing good medicine. You know, I don't mean to, you know, I shouldn't say that. That sounds elitist in and of itself, but that is the future. And I think it should be the standard, right? I think it should be the standard. You know, ONA is the standard, VERDA is the standard, right? These are the standards. And if you look at the data, and this is why I think it's so important to have you on the podcast. If you look at the data for this population, right? Medicaid, food shelter, right? Because I read that article from Nina Teicholz in the Medscape. Guys, go check it out. If you haven't, Jack will put it in the show notes. Okay, it's richer or poorer, you know, for richer or for poorer. And it talked about, Miss Ephraim,
yeah. Yes.
right? And it
Yes.
talked about Miss, what was it, Gonzalez, right?
Yes. Samuel
And
Gonzalez. Yes.
yeah, and how they, you know, one of them was in a shelter, okay, doing this diet, reversing her PCOS,
Yes.
right?
Yes.
And the story is so impactful. And the trick here is it can reach any class. It can reach the employee class, the people, the CEO class that we were talking about. It can reach the people on Medicaid. You can be in a UK clinic. You can be in a clinic in Israel and still see amazing results. And the reason for that is we live in a toxic, addictive food environment.
Right.
And we are literally
Yeah.
helping our patients come away from that. And if you look at the data, which was the Faith DM trial, took people in a food pantry and gave them whole grains, a bunch of rice, and a food pyramid nutrition plan, and their diabetes didn't get better. And here you are helping people who are on SNAP benefits, and their A1C is improving. I think it's a
Yes,
miracle.
Yeah.
And I think you're doing
Actually,
amazing work.
well, thank you. It's really encouraging to hear your words. So thank you very much. Yeah, I think that we out of our cohort on insulin also, all but one was able to get off insulin. And the one that didn't was pretty non-compliant, but he still was somewhat compliant, and his insulin went down from 122 units to 20 units. So we didn't get him off insulin, but we got him to really decrease the insulin, which is also significant to me because it decreased his hunger. He's grateful for it, even though he's not 100%. And you know, nobody really is 100% anyway. We're all, you know, most of the time, but then people fall off, and I think they definitely fall off, but they get back on. This is what we're seeing. People get back
By
on.
not giving up on them and keep going forward. And I think, you know, you make the rest of us look bad because you have every obstacle against you and you're doing this, and your clients, your patients are doing that. That's a huge thing because so many people will say, well, the inner city is just like they won't learn. I took care of some Hispanic females up in Vacaville, California. They were awesome and they did amazing. And I'll do a quick commercial, even though they're not sponsoring us, but health coach said, we'll send them food. I go, there's not going to be a market for you guys. They go, we want to help, Brian. If it can help, we'll do it. We had Keto Mojo send in stuff. We had other people,
That's
Rosettes,
awesome.
you know, other people go, look, let's let them, like, because the food they were eating was horrific when you saw their break room. But they did so well, and they had a blast doing it. They weren't deprived, they weren't miserable, and their mood was getting better, PCOS getting better. We're seeing these things, that are miracles, and they go, you can't help these people, they're not going to change. I go, I bet they will. I mean, if people believe and they get the right tools, they will. It's just because you've been doing the wrong thing, and that's why you're not improving, and then you sell off the community.
Right.
Like
I mean, they're
What
so
Tony
grateful.
Hampton's doing. He goes, look, these guys can't get vegetables in our neighborhood because then the stores are like, no one's buying it, so why should we have it? They goes, my people will buy it if you have it. Right. So he's changed his community that way.
Yeah. Yeah. It's a matter of giving a chance and believing, in the person that you're sitting in front of, or across the screen from. But it's really, really, what, that's the beauty of medicine, really, discovering the person and connecting with that person and believing in them. And that belief changes everything. I think that that's the real key, because they feel like somebody is, we've had a few patients, for example, not really take us seriously at the beginning. They didn't understand that we meant it, that if we're not going to give up on you, and if you go off, then we're here for you when you come back, and we're not gonna, we're here to be your cheerleader. And I think we saw how surprised those patients were that, we're behind you and we're not going to let you go. I don't think they had the expectation that that was going to be there, especially because they're getting this for free at this point. So when they get it for free, there is an element there that's lacking, which is the motivation, that the intermittent, there is something to be said to paying for your own treatment, right? And we don't have that element here. And at some level, I wish we did. Like, I wish they could pay like $5 a month for the service, because it is a commitment, but it doesn't seem to be necessary, actually.
Well, and
So
that's a huge point, because there's studies showing that if you're paying for something, you're more likely to use it. You're going to have a better outcome because there's some
right,
pain involved. And I was going to
right,
ask you, and obviously medicine, what we're doing, there's financial. So I'm looking at it from your perspective. I got out of the system because I was getting paid for a 10-minute appointment. I spent an hour and a half with the patient trying to get him not to get diabetes. So how are you doing it with a Medicaid type system for you? Like how are you doing it? Like, technically, is it giving them handout and using less of your time? Because I'll sit with a patient for an hour and a half now and try to get this in their head. And these are
right,
a different, a different population. So how are you getting
right.
these people to understand this? And, is it the app? Is it like, how are you doing it?
Well, if it were dependent on the 5-minute visit that you're allowed, right, that would never work. So fortunately, the patients are referred to ONA. And when they're referred to ONA Health, then the process starts. So it really, like, primary care doctors can refer to us so that they can actually take care of this. It's kind of like, say you have a person with, I don't know, like you send a knee pain and you send them to PT. Well, you're clearly not going to do the PT treatment in your office as a primary care doctor, right? So what we're saying is, let us help you take care of your patient. Send them to us, and we work with the primary care doctor, and kind of allow that teaching that needs a lot of time to happen. You can't do it unless it's like a private thing, right? So I mean, hopefully one day Medicaid will pay for ONA, and that's the goal.
So do you do group classes where you can have 10 people together or 15 people at one time and explain all these concepts to them? Or is it one-on-one, or how's it, like, technically,
For
how are you
now, it's
doing it?
one-on-one, but we also have group classes. We have both, but mostly it's one-on-one still at the moment. But we have like group sessions as well.
That's
But
amazing.
yeah, it's a challenge. How to do this is a challenge, but we're figuring it out.
Yeah, can I
The
tell you,
commercialization.
the economic models don't support, it's very difficult, right? It's very difficult. The only model I see,
Absolutely.
and maybe you can explore that, is the RPM model, the chronic care model, within the insurance system. But then what happens when you want to be a great doc? That's that you're still limited in that scope through the RPM model. So it's a challenge figuring out how to deliver really effective care.
Yeah, the incentives are misaligned, so it's a real problem, and it's a real problem, but that's where we're trying to understand the system and try to make it work. So hopefully we will, because somehow it has to happen. Otherwise, I don't know how the American system can survive, just getting worse and worse and sicker.
Yeah,
So
it's
at
not going
some
to
level,
survive. But doing what you're doing, like I hear every new administration come in and say, we're going to cut the cost of insulin. We're going to cut the cost of insulin. Insulin's still really expensive. And you go, okay, is it better to get everyone except one person off of insulin? Isn't that cheaper in the long run? For sure, right? And then the ill effects of insulin with weight gain and mental health issues and cardiovascular and amputations and wound care and all this money our system is spending on, and it's incredible. So doctors like you should be rewarded for saying, let's taper. The way the system works now is you get paid more based on how many medicines you give the patient, right? If you're giving them a statin drug, you get paid more because you're within the standard of care, not the MIPS and MEPS and all this stuff we talk about. You go, wait a minute, once we get them to reverse their disease or put it into remission, whatever you want to call it, isn't that better for the system and the patient's health long term?
depends who you ask, right? That's the
Yeah.
problem in the system. We not everybody has the same motivations we do. So it's really complicated, unfortunately.
I want to touch on a point you said, which was the compliance. We have the same sort of split. We have the CEO population, and we have people from these large employers that are so grateful to have access to a program like this. They don't have to pay anything to be involved, and I don't see any difference. In fact, I would agree with what you're seeing. I see a slight higher rate of compliance in the sort of the production line workers, the
Right.
the people, sort of making the equipment, welding, truckers, right? So we have a big trucking company, and you can't go tell a trucker to go eat whole grains. No, they have like there's rest stops and there's so like you have to be flexible to what people have access to. But I'm seeing the exact same thing, which is this idea that people who don't have a PhD or aren't wealthy, they can't do it. And when I hear people say that telling the population to lower the consumption of processed foods or lower their carbs, that's elitist, I can't help but think it's actually the opposite, right? Saying
Totally
someone
agree with
who's
you.
poor can't do it is elitist
Oh
or
yeah,
should.
it's so
Yeah.
Well, I could tell you
very,
from my
very
experience
paternalistic.
in
Yeah,
Guatemala,
everybody's talking at
the
once.
farther we are from the city, the healthier the people are. The more we get to the city, the more they need help, right? They're sitting at desk jobs. The guys out working in the field all day, eating eggs and meat, vegetables if they're growing them. They're doing way better than people that have, until recently, because now all the soda companies have infiltrated everywhere. It's cheaper to get soda than it is water in some of these communities. And they go, oh, gosh, and they believe they market to them. If you're diabetic, you need this for your energy to drink soda with sugar in it. Right. And it's so hard to
God,
overcome that. But once people
it's
see
so bad.
that, who was I just talking to, Tro? Was that on our podcast or my other? But someone says he takes a sugar strip and sticks in the soda and says, look what this is like what sugar is. This is how much sugar is in that. And people see that. Yeah, you don't have to have a PhD to go, oh, that's not good. There's a lot of sugar in that, So yeah, it's amazing how we think that people have to be in. And I agree with you, Troy. I think some of my blue collar, hardworking people, they do better than the CEOs of companies. And part of it's because when you're a CEO, you get free meals, you wine and dine people, and you're out drinking more and you're eating more food that you're gonna go have bread at dinner. And so sometimes I've actually one of my patients is a CEO of a company, pretty big company. And where they had a food court where they just had food all day. He goes, no, we're moving. He moved the company somewhere else to get away from that because I can't, if I'm there, I'm eating this stuff and I gain weight, my sugars get crazy. And so he goes, no, we're going to move to where we're not exposed to food. And if we do, we're going to have healthy lunches shipped in and, that kind of thing.
Great.
What an amazing thing. Yeah. I'm just curious, Dr. Glandt, um, how, how do you feel about, the scientists at large it was just in Times, this past week saying that maybe processed food is healthy, and critics of people trying to reach this population with dietary interventions saying it's elitist. Like, how do you respond to that? when you are there in the Bronx, you are, you are probably the families, everybody. Like, how do you respond to that? How does that make you feel when you hear those types of criticisms?
I mean, first of all, just all you have to do is look around you in the Bronx, and what you feel is that it's intoxicated. That's what I feel. I feel like everybody is intoxicated with junk. It's like, where is the humanity here? Let's go back to the real food. I mean, the amount at the beginning when the process starts, they start taking pictures of what they eat, and you see what they eat, patients, and you cannot believe it's like junk food after junk food. How can this be, a human diet? So, I mean, there's so much politics here and so many layers of ugliness and what's happened to us over the last 50 years that I think we all just need to take a step back and say, okay, it's not about elitist, it's just, there's logic, there's common sense here. How can anything that's built with that where all the ingredients are illegible be good for you? Where you don't understand anything you're eating. This cannot be good for you. Let's just go back. I always say, let's go back 100 years. But of course, if we want to reverse disease, we have to go much more back, right? If you eat like 100 years ago, we would have avoided the disease. By the time we're sick, we have to be a lot stricter and really get rid of the carbs entirely. But my response is, just where's the humanity here? Take away all the junk, and there's so much of it, and look at human evolution. It does, nothing makes sense, and actually the patients get it. They get it when you actually explain it to them. They're like, they get it. That's my experience. They're like, yeah, you're right. And then if you think about just like their grandparents, especially the Latin, well, actually both, like the Black, the African American, there are all sorts of Africans. The Bronx it's a big hodgepodge of cultures, but in every case, there's a good use of animal fat, and they weren't afraid of it. The grandmothers were not afraid of real animal fat. So I'm like, just think about that, right? Just re-embrace this, and now we have to be more extreme because there's no choice, because we have to reverse all this disease. So we have to take away all the carbs. But I think that this elite, thinking that it's elite it's an elite. I mean, I think what you're trying to say is that it's being very paternalistic towards people, to tell them, for us to decide, that they should be able to eat junk food if they want, right? Oh,
we've the word paternalism, I've been thinking about that. I don't think it's paternalism. I think it's authoritarian, believing that junk food is healthy and we should just accept it for everybody.
Right. It's even more extreme.
What
you're saying is definitely much more. Yeah, it's true. It's more extreme.
Yeah, because it's at the heart of it, right? It's saying that if you're poor, that's what you deserve. And I'm sorry, humans, as you said, bringing it back to the human, they deserve health, right? Health is a birthright.
Not just the humans. What about you guys? Have all the squirrels that are morbidly obese now too, right? Because they're eating pizza and all the junk food that's left over from the people, right? That doesn't happen in nature anywhere. I'm
embarrassed, because we probably share squirrels somewhere between her office and mine. There's probably 15 common squirrels, and I haven't yet. I have to invite you out for lunch, Dr. Glandt. That's what I have to do.
Let's meet. Absolutely.
Your city, and I'm embarrassed to say we haven't met yet. And I got to come out and visit you one day. That's what I got to do.
That'd be super. That'd be really great. But
the squirrels are really fat. They're really fat, Brian. Yeah, the raccoon, the rats in New York City they're a different breed. I mean, talking about food addiction. I saw a meme actually from JFK Airport. A raccoon broke into a candy store like opened up like right underneath the register, stole a Twizzlers bag and like popped back into its hole.
Oh my gosh.
That's
Yeah.
the animals we
They're
have.
addicted, man.
There's a pizza. There was this
As long as they
pigeon.
moderate. Did you talk to him about moderating,
Yeah,
bro?
somebody brought a pizza, and one of the New York City pigeons, literally, I kid you not, or some other animal, came and literally picked up the whole pizza and just flew away with the pizza. You know,
I mean, sugar is good, right? That's the problem. And how can we not be addicted to it? But there's just we are so far from the human diet, so far that, you know, the whole concept of eating in moderation, even that is really nowhere near what we should be eating.
So what's your idea now? Like what's your long-term vision right now? Are you saying, okay, I have data now. Are you going to publish this data, get it out to, you know, say, hey, we need to change what we're doing?
JMH. She just had
Yeah,
an
I know,
article.
but I mean, is this an is going to be an ongoing study of these people looking at long-term outcomes? And yeah, I'm just thinking the standard of care has to change, is what I'm saying. The standard of care is horrific and people just don't see it. But when people
Right.
like you come along and go, we could do it a different way. And here, look, here's my numbers. Here's how much insulin we're using at my clinic. Here's how many wounds we're treating. And when you start looking at from unfortunately, my sad, what is it called? When you're in medicine too long, Troy, you start getting cynical about everything.
Yeah,
It's
cynical.
going to come back to money. How much money can you save the system? And
Yeah.
the issues, it's going to come back to money. And then the problem is a ton of money is going into, you know, helping the politicians to allow more processed food and more sugar and more drugs on people, right? And it's not the right
Right.
way, but it's where the money is right now, unfortunately.
Right, right. No question about it. We have so many things against us. Yeah, I mean, I think very soon we're gonna be treating, I don't wanna jinx this yet, but I think a few good thousand patients in the next year. And so I think that data will be very valuable.
And you're not providing food for the patients, right? You're just giving them recommendations on how to use the food allotment that they have. Because I remember a friend of mine has a gym here in San Diego, and right next to him is the WIC program with the women and children.
Oh,
And I
terrible.
saw what
Yeah.
they were giving them. I'm like, you've got to be kidding me. There was no food there. It was Cheez-Its. It was like fruit punch. It was soda. It was like, there was nothing there that I go, that's nutritious. It was
Yeah,
calories, but there was zero
we'll get
nutrition.
there. Yeah. My
How can,
ultimate dream is,
yeah.
yeah, sorry. Go ahead.
I'm just
No,
wondering, how
it's
can people look at that and go, yeah, that's a good thing to give people. Like they'll enjoy having cereal and, you know, sugary cereal, and there was nothing of nutritional value. So if you just ate that, you're not going to have a better quality of life at all.
absolutely, totally agree with that. So it's heartbreaking, really, when you see what they're receiving. And yeah, my ultimate dream is to be able to improve things, and even we're actually now talking to soup kitchen. There are many things. There are many projects that I think, you know, we have to link this to the people providing the food as well. So, you know, somehow, you know, there's a lot to do. There's a lot of work to do, and yeah, we'll do it.
Absolutely.
That's it.
I'm excited to see the next study. The one in the Journal of Metabolic Health was great. You know, your clinic audit. I can't wait to read the next one. And we'll have Jack put all these in the show notes. You're doing absolutely amazing work. I know you have a heart out, you know, so we'll respect that heart out. Brian, any other questions before we
I
end?
knew the hour would go by too fast. No, I think it's amazing. I think you know, it had my mind spinning on things, and you always thought, hey, when we go to Guatemala, if we take chickens, like little chickens, and let people raise them and give them pans and let them, like, you could really help people with diabetes, and it's always you know, looking at getting them good nutrition. And I'm convinced, I don't have data on this yet, but pretty convinced in a lot of underserved areas, it's malnutrition that has you're just not producing enough insulin, I think. So, and they can become insulin resistant. Then, you know, so I'm seeing guys 150 pounds in Guatemala that are type 2 diabetic with sugars like 400. It's like, what the heck is this? Is it all nutrition? And you know, there's some nutritional things that maybe will help out. So hopefully if we can, you know, do some studies and realize that can be contributing too. And then one of the known risk factors for obesity and diabetes is food insecurity in childhood. So
Right.
all your patients are going through that also. So it's like, wow, when they realize, hey, if I'm eating good protein source, a good healthy fat source, that they're going to do a lot better than eating, processed junk forever. So I'm
No
very
question.
encouraged by what you're doing. I think it's so critical. I think people like you will save the healthcare system. There's no other way out, really, honestly.
Well, we're all trying, right? Everyone's trying to do their part. So we have to keep doing this. I also see the movement growing, right? As we're talking about before, we're more and more doctors are opening their ears and understanding that they're burnt out. The regular doctor is burnt out completely. They're so tired of giving more and more meds. There's no joy in that. I recently had a new endo sit by my side as I was seeing patients, and I think he was shocked because he had never seen the patients leave the office so excited. It was such a different dynamic from what he was
You
used
give
to.
them hope. You give them hope that they can have a better life, because no one wants to be sick and miserable. But they're saying, I mean, I've dealt with this for years now. They go to I've had it multiple times where, patients would go to the endocrinologist, and endocrinologists go, you know what? Don't worry about all that stuff. Just eat whatever you want, and we'll give you more insulin to cover it. Don't worry. That's their mindset, because they're thinking we'll make the sugars better, but you're making the patient die. That's the
Right, right.
problem.
You're missing
So
the whole point.
we have to have more endocrinologists like you, because when you're an endocrinologist, you could say, when they ask me in Troy, are you guys endocrinologists? No, we're not. Okay, then let us do our job. Leave us alone. Right? When you go, yeah, I am an endocrinologist. Here's my data. Then all of a sudden it has more credibility. When we have people like Brett Sher, cardiology, Dr. Palmer
Right,
in psychiatry, we have all these people that are top notch. They're helping their patients. Right? So
right.
that's what we
Well,
wanted
that's
in
just by
medicine to
chance.
do, and we forget.
Yep. Yes, I was just thinking, just a total side. I was remembering when I actually volunteered in Guyana once, and it makes me think that the patients really had sugars like uniformly of 400.
Mhm.
This is and one of the things that I was talking about, this totally, I'm sorry, like I totally sidetracked here, but I was remembering what you were talking about Guatemala, and all I was saying is like, please grow your own chickens. This is what I was
Mhm.
saying to the patients. I was
Yeah, we
just
think
reminding
alike, huh? Yeah, you go, if you have a
yeah.
good protein source, you'll do that much better. And if you put on muscle, it's going to make you more insulin sensitive. And we can really do some amazing things rather than just throwing a
Yeah,
bunch of pills around.
absolutely. Well, thank you
Tro, any
guys.
words of
Really
wisdom on our way
appreciate it.
out? We have 3 minutes.
No, I'm just, I knew you were doing good work. I remember sitting down, I forget what conference it was, but I knew you were up to good work, uh, a long time ago. And then to see Nina really highlight the lives that you're helping really made it hit home. It brought the humanity back to it. And yeah, I'm gonna say it again. I'm embarrassed that I haven't had a lunch with you or sat down with you, and you're so
Let's
close.
do
So
it.
I'm gonna, this is me committing to the world, because now they all heard it, that we're gonna have some lunch, and you're doing great things, and I'm happy.
Some good fat and
Um,
protein together.
yeah, I'm really happy that you're doing great stuff, and I know Mark's talked a lot about the work you guys are doing together. So it's
Um,
just, we gotta
Thank you
we
guys.
gotta we gotta help you. So when you make it big, remember us small time internal medicine docs,
Uh, well,
anyway,
again,
I'm gonna be
we're
seeing you.
we're
I
just.
may see you in DC actually, so we'll see. Hopefully I can
Oh, that'd be
up there,
fantastic. That'd be
so
fantastic.
the rally, we'll put that information in there, since you guys are sister brother and or since you're sisters, you and Jess Apple. We'll also put the Metabolic Revolution info in the show notes.
Let's do it.
Okay,
Perfect.
awesome.
Awesome. Thanks so much, Doc. Have a great
All
weekend.
right.
Thanks for spending your time with us. We appreciate it.
Oh, thank you guys. Bye bye.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.